Good afternoon. Thank you, Dr. Raji and organizing team for their kind invitation.
We have not yet started the MD pain medicine or diploma.
So we have started fellowship in pain medicine 4 years back.
MD.
MD is
But that will involve multiple specialty, from medicine to anesthesia, surgery to pediatrics to gynecology, multi-specialty, nahi? Super specialty, DM.
now, sir, the DM pain medicine has been started in AIMS Rishikesh. I think 4 years back they have started.
Rabi Kumar started.
So we are planning to start in near future, but right now we are doing fellowship in pain
No
medicine.
problem. I just want to know where are we?
So I will be presenting on sacroiliac joint injection, basically fluoroscopy guided. As you know that the sacroiliac joint has a great variability external contours, and most of the time this is auricular in form. It's a C shape in male patients and L shape in female patients, and usually the articular surface extends from the S1 to S3 foramen and sometimes up to S4 also. And as you know, it's a diatrial joint that has some synovial component. And the SI joint itself serves as a major shock absorbing force transducer that is implemented during the weight bearing activity. This is very important joint, one of the largest joint in the body. And coming to a little bit more on anatomy, that's a probable form, and it's about 20-degree ventrolateral to the dorsal at S1 level. As you can see this here, it's very difficult to penetrate the needle for SI joint. But this is more or less orientation is surface less oblique. In prone position by posterior approach, one can approach this joint for any injection. And this obliquity is different from person to person, while the proper form remains constant. But and this have very multiple ligaments are there, especially anteriorly and posteriorly. That gives some this enhanced stability by increasing the friction of SI joint and contribute to the self-locking mechanism. And especially the lower part of the joint, those ligaments they offer proprioceptive feedback with rich plexus of articular receptor. This part of the joint is very sensitive and have a number of nerve endings. Coming to different causes of SI joint pain, that some most times unilateral. It may present in ankylosing spondylosis, tubercle psoriasis, then Reiter syndrome, inflammatory bowel disease, and if it's a bilateral, you can have chronic non-traumatic sacroiliitis. But most common painful SI joint presentation is usually in mechanical injuries with trauma, and sometimes additional lumbar arthropathy and fusion. If patient has had some surgery, those patients can have SI joint dysfunction. Coming to symptomatology, usually these patients have painful catching and increased pain while they are having some loading in the lower extremity, and pain may be induced by simple movement like trunk shift, sneezing or turning in the bed, or especially if the patient is ascending or descending in the staircases, and if the provocative landing after a jump or hop. And in this patient, pain is usually not provoked by Vasva maneuver. And these patients, especially pure SI joint dysfunction, they never have any paresthesia, numbness or weakness. Now coming to evaluation, it's basically clinical diagnosis is very important most time, but we go by clinical diagnosis only. And there is a battery of tests which can be performed, especially those may be manual compression tests or provocative tests. Basically, one can do dorsolateral pelvic compression. If the patient feel pain and have a finger, you can have finger test. If the patient complains that I am having pain in that part of the SI joint or buttock, that means the patient is having some SI dysfunction. Especially axial femoral compression test can be done, and forward flexion, there is some Waldorf phenomena can be performed. And there is a battery of probability test, though they are not any more specific or sensitivity, especially Gillette test, Patrick test, that is Faber test, then Ganser test. These have some relevance, especially in SI joint dysfunction and midline cycle test. But all these tests, they are not confirmatory, and they have shown some very little diagnostic value compared to, and the standard gold standard is give some SI joint injection to confirm the diagnosis of SI joint orthopathy. Coming to SI joint innervation, that have a very complex innervation, that this usually that now supplied that medial branch or dorsal ramus of L5, even L4, then little branches of the dorsal ramus of S1, S2, S3, and sometimes S4 also. So it's a very complex, and the anatomy is very important, especially you are doing some, apart from after conducting or performing SI joint, diagnostic SI joint injection, if you want to have prolonged relief in those patients, you can perform some thermocoagulation. Why fluoroscopy? Though these injection can be performed easily by SI joint, this ultrasound guided SI joint injection, but fluoroscopy is gold standard for performing SI joint injection, because one can have specially designed joint and venereal, and it improves the precision, accuracy, and clinical outcome. And most time we use fluoroscopic C-arm to conduct these blocks. Coming to injection technique, basically it's interarticular classical oblique ridge by posterior approach, and as I said, it can diagnose the course of pain. Usually these blocks are performed prone fusion fluoroscopy and strictly steroid technique used. And in classical oblique approach, the C arm initially places in direct anterior posterior so that you can view the SI joint total. And once you have visualized the SI joint, you can have two lines, two joint lines. One is medial joint line, one is lateral joint line. So basically you align both the lines to make a single line, and for that you have to tilt the C-arm in contralateral oblique view so that there is alignment of both anterior posterior joint line. This is the classical P oblique view approach. You can see that slightly contralateral oblique view is there. You can see that that in this view, fluoroscopy view, more or less this is anterior joint line, this is the posterior joint line, and at the lower one third of this, lower half of this, there is a single line. So this is posterior joint line, this is basically anterior joint line. So target area is posterior one third of this joint line. This is a marker where we have to insert the needle. This is after inserting needle and giving dye. You can see that there is a very good spread of dye from anterior superior to inferior aspect of the joint. In lateral view, you can see that there is a clear delineation of the whole of the joint by the radio contrast material. In this, for SI joint injection for diagnostic, we usually use 2 to 4 ml of xylocaine 2%. And if you want to convert this block as a therapeutic block, you can use some steroids, especially dapamidrol or dexamethasone. You can use up to 8 milligram or dapamidrol 80 milligram. It's a big joint. Safely 2 to 4 ml can be used in total. And complication, this needle tip may not be joint. It can go in the pelvic viscera. One has to be careful. At all time, the needle should be closer to the bone. And as the chances of infection, hematoma can occur, but most of it's very safe, easy, and very quickly can be performed. And it's a very good role in diagnosing the pain generated in SI joint. Thank you very much.
Any question? Question?